So why are we here? We often talk about the healthcare system. That's very commonly used, right? The healthcare system's good or it's bad, or the healthcare system is being fixed, usually by the other folks in the other Washington, the evil Washington, as I call it. But the healthcare system is an idea, is something we always throw around. The healthcare system is going to do this or that. In fact, a lot of people who study the healthcare system don't think of it as a system at all. In fact, I call it the unsystem. You know, so if you look up the word for system, it means something that's interrelated, connected, organized, intended to get a certain goal. And in fact, there's really no system. If you think about what we have a lot of people working very hard trying to deliver good care, but it's uncoordinated. It's in silos. Some of those silos are excellent, and many of you represent centers that are excellent silos of excellence, if you will. But we all know that not everybody can be a silo of excellence. It's not like Lake Wobegon where everybody can be above average. And so how do you make a system happen? And I guess that's what we're here about today, trying to understand how to create a real system. So the speakers today, in varied and I think unique ways, all in some way are working towards making a better healthcare system. And that's the work that we're trying to talk about today. What they're really trying to do is retrofit our system, which is arguably not a system. And what they're essentially doing is reinventing it. And that's what we're talking about. So why surgery? Because we could be talking about pediatrics, or cardiology, or any number of fields. Well, I'm a surgeon, first of all, but more importantly, surgery is a really exposed area. You come into a hospital healthy for surgery most often, or with a very fixed problem, and you either leave with that problem fixed, or maybe you don't. It's very obvious when there's a problem in surgery. Second of all, surgical costs. You know, some of the biggest drivers in healthcare are surgical costs and technology. So it's very exposed from a healthcare utilization perspective. So when we have an opportunity to figure out how to make it work better, we should take advantage of it. Lastly, surgical decision-making often happens in a quiet place, one patient, one surgeon, in a dark, a lit room, but it's not well lit to everybody else who wants to study it. The thresholds for decision-making, risk-taking, appropriateness of care, those are conversations that need to be understood so we could figure out why healthcare utilization varies so dramatically, city to city, county to county. And that's the reasons why surgery is such a nice area to study and work on, and something that we all should have as a top priority. So in all these ways, safety, appropriateness of care, quality, cost, in all these ways, a reinvention of the surgical system is what's in order. And like the field of aviation, Dr. Carl is an expert in aviation and surgery. Like the field of aviation that went through a sea change to make it safer, higher quality, better cost, more cost efficient, surgery is going through that transition now. And it's through the work of many people in this room that we're going to make that happen. So if nothing else, we need to have a discussion about that transition and how to make it happen. And luckily, between members of the source community and partners of the source community, we have a lot of intellectual resources to help advance this discussion.
I just want to start with a few comments about why I think this is so important and why we can look at training, education, and certification really as a driver for system and process change. You've seen Dr. Cheney and Farhud Farja talk a lot about hospital variation. We've talked about errors, complications, tracking those errors. Really, there's been a growing recognition over the last few years that medical errors are a driving force behind patient death, patient morbidity, and hospital cost. Huge cost, huge problem. It's really led to an environment with a zero tolerance for errors. Dr. Cheney briefly described this same paper, a closed claim review, but I just want to dive into the data just a little bit more. So if you look, and here's my pointer. If you look at the closed claims, these are patient injuries that led to a malpractice settlement, and the cause for them, error in judgment in 66%, technical competence, lack of technical competence or knowledge in 41%, and communication breakdown in 24%. And you can see the breakdown of the communication errors, handoff, with I think Dr. Van Eaton may be talking about later, lack of lines of responsibility. Patient-related factors, things like comorbid conditions, their illness, underlying illness, that was only in 44% of people. So if you look at communication breakdown, lack of technical abilities, or errors in judgment, Those are the driving factors behind a lot of the errors that are made that impact patient care. So does training impact outcomes? Because you could argue that this doesn't have to do with training, it doesn't have to do with education, it doesn't have to do with simulation. It has to do with systems factors, checklists, and whether or not the hospital has a system to identify when these problems happen. But in fact, I think that there's some growing evidence that the training that we give to our residents and to our physicians in practice impacts outcomes. So this is a relatively recent paper. It's in obstetrics and gynecology. As far as I know, there's no similar study in surgery. But this took a look at almost 5 million deliveries performed by 4,000 physicians who are trained in 107 different residency programs. And they separated out based on the training program that those physicians completed. And if you look, the top quintile, the best quintile, had a complication rate of around 11%. Those trained in the worst programs had a complication rate of 14%. So a very significant, when you're talking about 4 million deliveries, very significant increase in the number of complications related specifically to where those people were trained. Now you could say, well, the bad physicians are being trained in bad programs. But in fact, if you norm this based on board certification scores, this difference still persists. What that means is the good residency programs are producing graduates with low complication rates, and the bad residency programs are training physicians with bad complication rates. So some programs are training their physicians better than others. Well, how can we improve our outcomes, reduce our variation, prevent errors, and improve our efficiency? So there's a lot of things we can do on the hospital or systems level. My interest is in training and certification. How can we train residents better? How can we train practicing physicians better? And how can we certify them? And how can we maintain that proficiency over time? Well, what's the current model? How do we teach people now? Well, we teach people in lectures and seminars. Lectures like this. You sit in a room, the lights are dim, people fall asleep. There might be a multiple choice test at the end of the lecture or at the end of the year. But most of the training is on the job. We teach our residents because they follow us around. We let them do pieces of an operation. We let them participate in the care of our patients. What's wrong with that? Well, it's disorganized. A resident who works with me this month might do 4 colon operations. Next month, they might do 1. If I'm out of town or if I hurt my foot again like I did a couple months ago, they might not do any. It's time-consuming. It's not based on performance. It's based on time or numbers. So a resident has to complete 1,200 cases. Doesn't mean they completed them well. It's very costly. It doesn't work for adult learners. Adult learners don't learn this way. In fact, pediatric learners don't learn this way. My wife, who's a high school teacher, could tell you that. Certification and assessment is difficult. If we don't have a measure of performance, we can't tell if somebody does it well or poorly. And it does impact patient safety. We're letting trainees learn on our patients. So what about simulation? Well, we've talked a lot about aviation today. This is one of the arenas where we're learning from aviation. Simulation has been present in aviation for a long time, and this is the Link trainer from 1931. And we talk about how long change takes. Change in the aviation industry took a long time. A big part of that was this movement in simulation. Well, now it's required. All pilots have to train in simulators, and they have to train specific to the aircraft that they fly. It's part of their continuing education. So they don't just train when they're in school learning to be a pilot. They train throughout their career. And the technical skill, pushing the stick, turning the dials, that's only a very small part of simulation in aviation. The team building, the team training is really the key to the aviation simulation. So what can simulation provide? Well, it's centered on the needs of the learner, not the patient. If you need to repeat something 100 times before you get it, in the simulation lab, we can let you do it 100 times. I can let a resident in the simulation lab make a mistake and learn how to recover from that mistake. I can't do that in the operating room because I can't allow that injury to my patient to happen to then allow the resident to figure out how to fix that injury. You can repeat it as many times as you want. You get feedback. So you know at the end of a simulation how you did. You can get a score. And you can know what your target score is, and you have to keep practicing until you get to that target score. You can work at your own pace, and you have a permission to fail. You can make a mistake. You can learn the best way to do something. You can expose new or unusual circumstances. In your residency program, you might never be exposed to malignant hyperthermia. You might never be exposed to an air embolism, but we can make it happen in the simulation lab. And we can give objective certification of performance, competency-based promotion. So what are we doing here at the UW? Just as an example, we have the Institute for Simulation and Interprofessional Studies, or ISIS. Now it's important, this is not just a Department of Surgery initiative, although obviously supported heavily by Dr. Pellegrini, but it is more than 20 departments, more than 50 courses. It's focused at medical students, residents, and physicians in practice. We do a lot of things in the simulation lab. There's task training, so just how do you do laparoscopic surgery? How do you move around in a 3D space? This is kind of the analogy to flying. How do you turn the dials? How do you move the yoke of the airplane? This is just how do you do a technique. We do critical care, like central line training, childbirth and delivery, but we also do team training where we can simulate various team scenarios and really coach people and teach them how to manage teams in a crisis. I want to make the point, though, again, simulation training is not just for the residents. It's not just for the trainees. And it really is good, and I think we'll see a growing use of simulation and training for physicians in practice. There's growing data that warm-up through simulation reduces errors. So just like you wouldn't expect a basketball player to go onto the court without warming up first, surgeons should probably warm up before they operate on a patient. And I think we're going to see that in the future with simulation playing that role of warm-up. Even patient-specific warm-up. So you could load a patient's data into your simulator and practice the operation on that particular patient's physiology, on that particular patient's anatomy before doing the operation. Maintenance of skills and learning new skills. What happens when a new technology comes down the road? How do you learn that new technology? Re-entry into the workforce. So if you're out for 6 months, if you're out for 2 years, if you're in Afghanistan for 6 months and haven't done a laparoscopic procedure in that amount of time, how do you re-enter the workforce? How do you credential, and how do you improve as a team? I want to give an example of a specific project that we're working on and try to show how simulation and training can impact patient safety. So this is our central line project here at the UW. Central venous catheterization, one of the most common bedside procedures that we perform, but it has a high rate of complications. Some estimates as high as 17%. And many of the items on the checklist that Dr. Peterson discussed, things like line infections, directly relate to this central line and central venous catheterization. It can be infectious. You can have blood clots, thrombosis. You can have mechanical problems like pneumothorax or air embolism. More than $50,000 cost per complication. It's a CMS never event, meaning that if a complication happens, the hospital doesn't get paid for taking care of that complication. And we know that there's poor compliance with best practices. There's very good evidence for things like ultrasound use during central venous catheterization. Yet a lot of people don't use an ultrasound because they were never trained and never learned how to use an ultrasound. So we've developed a project in ISIS in collaboration with the UW and Harborview. It's not just for residents, all attendings and residents who place lines, all departments. It consists of a cognitive simulator where you go online, you learn about the procedure, you learn how to do the procedure, you learn best practices, you learn the IHI bundle. Then you take an exam at the end of it. You have to pass that exam. Once you pass that exam, you move on to the technical skills simulation. So we have not just how you stick the catheter in, but all of the aspects of the line. How do you get the patient ready? How do you get consent? Is there consent on the chart? How do you prep and drape the patient? How do you put the line in under ultrasound guidance? What dressing do you put on it? Do you check an x-ray afterwards? You have to show competence on the model, on the mannequin, before you're allowed to do it in a human. And as of July of next year, if you don't have the card that certifies you've been through that training, you're not going to be allowed to put the line in. So this is just a still shot of our cognitive trainer. It has video, it has ultrasound, it has what do you do in the case of complications. And here's an example of the mannequin just showing putting in the line. So we're going to try to tie that to patient outcomes. Does compliance with best practices improve? Do we see, is ultrasound being used more frequently? Are we using the right dressings? Do the complication rates go down? Do we have fewer line infections? Do we have fewer pneumothoraxes? And see, is it cost effective? If we save 2 complications and we save the hospital $100,000, does that pay for the cost of the program? So that's just one example. We have a lot of examples of programs, and I think we're going to be seeing more and more of this both for training of residents as well as for maintenance of certification, and what I'm really interested in, introduction of new technology. How do we introduce something new? So these are my twin 9-year-olds down there. One of them's learning laparoscopy, one of them's learning on a suture pad. I would welcome any of you who are interested in simulation, any of you who are interested in looking at how we can tie training into better patient outcomes. Feel free to contact me. I'd be happy to show you around, and we'd love to work with you. Thank you.
So a fascinating aspect of this conference today is that we're talking about many different levers that need to be pulled in order to help improve the quality of healthcare. And one lever that we haven't yet talked about is the patient-centered approach to improving quality in surgical care. And that's where we're headed today. And in particular, we're talking about preference-sensitive care today, which I want to talk about procedures in which patients are making value-based judgments about the available treatment options, and there's trade-offs between different treatment options regarding the risks and benefits of each option. So the Dartmouth Atlas estimates that about 1/3 of all medical care is preference-sensitive care, and Winberg and colleagues in the Dartmouth Atlas have repeatedly shown that there's wide regional variations in preference-sensitive care in the United States. So one example of unwarranted variation in preference-sensitive care has to do with knee replacement surgery, where you see large variations in the rate of surgery across the United States. And within hospital referral regions, we can track that within the Yakima area, you're less likely to have a knee replacement than if you live in the Olympia, Washington area. Washington State has done their own analysis. The Office of Finance and Management in the State Budget Office took a look at CHARS data to take a look at all inpatient hospitalizations and looked at rates of different surgical procedures across the state and found that there was substantial variation in your likelihood of having a knee replacement surgery and 8 other surgical procedures in Washington State, depending on where you live. Group Health took an interest in this and wanted to look at their own data using the same type of metrics to try to see where we might benchmark against the state. And Group Health is an integrated health plan and care delivery system providing care for 1 in 10 people in Washington State, or over 600,000 residents. What we found is that for Group Health overall, our rate of knee replacement surgery after adjusting for age and sex was right on the state average, which you think might drive complacency in thinking, well, we don't really need to do much about it. But what's interesting is that you need to begin to look at your trends over time and what happens within different regions in Group Health. So the dark lines on this graph reflect 3 main regions of Group Health's integrated delivery system: the central region in Seattle, east side in Bellevue, and south in Tacoma and Olympia area. And the dotted lines represent other regions on the state level using the same metrics. And what you can see is that Group Health started out at a rate of knee replacement surgery that was actually below the state average. But as time progressed, we have 2 areas that increased the rate of knee replacement surgery dramatically, and one area, Tacoma, continues to have knee replacement rates of surgery that nearly double what they are in the central Seattle region. But what is the right rate of knee replacement surgery, or any given elective surgical procedure? Well, the Dartmouth Atlas would say that variations are unwarranted when they're not consistent with the distribution of informed patient preferences. So the right rate for any given procedure would be based on the choices made by well-informed patients who are engaging in high-quality shared decision-making conversations with their providers. So shared decision-making itself is a process in which the physician shares with the patient all the relevant risk and benefit information on the various treatment alternatives, and then the patient shares with the physician all relevant personal information that might make one treatment option or side effect more or less tolerable than the others. And then both parties use that information to make a mutual decision. And shared decision-making discussions are often supplemented by decision aids. And decision aids are educational tools which provide up-to-date information about the condition, including risks and benefits, and where appropriate, they discuss the limits of the scientific knowledge of what the treatment options, risks, and benefits are, and about the long-term outcomes. They help patients clarify their own values regarding the different values and preferences for the risks and benefits. And they give them guidance and coaching in how they might think about their treatment options and make an informed decision in collaboration with their provider. So the expected outcomes of shared decision-making, as demonstrated by systematic reviews and over 40 randomized trials, are that we think that shared decision-making with high-quality decision aids actually improves patient knowledge of their health condition and of their treatment option. It tends to improve their satisfaction with their care and with their decision-making process overall. And it may, when applied broadly across a large delivery system, actually tell us what the right rate of demand for a given procedure would be and help reduce unwarranted variation in care by helping patients make more informed, values-based healthcare decisions. Interestingly, as Dave was mentioning, Washington State has taken a proactive approach on this to address unwarranted variation by putting into law. Governor Chris Gregoire in May of 2007 signed new legislation that recognized that when physicians use shared decision-making and a patient decision aid, that those conversations reflect a higher standard of informed consent than what's currently accepted in Washington State legislature. So the legislation recognizes shared decision-making as a higher standard of informed consent, potentially allowing for increased liability protection for providers that engage in this. The legislation would also directed in this legislation that the healthcare authority begin to conduct shared decision-making demonstration projects to assess the impact of shared decision-making on healthcare use and costs of care in state areas that provide care to state-supported healthcare, Medicaid and others. So Group Health actually took action on this and is undertaking a system-wide implementation of video-based patient decision aids for 12 preference-sensitive health conditions related to elective surgical procedures. And so we've brought together a multidisciplinary team that is implementing this across the delivery system, made up of administrative and clinical leaders and staff from the delivery system and health plan. We're addressing 12 different areas, including back care programs, so treatment choices for spinal stenosis and herniated disc, hip osteoarthritis, knee osteoarthritis, and coronary disease. And you can see there that the volume of preference-sensitive care that we believe we have every year in our integrated group practice, as well as the annual volume of related procedures that might be impacted by implementing shared decision-making in our integrated group practice. Continuing on, we're implementing around treatment choices for prostate cancer, benign prostate hyperplasia, uterine fibroids, abnormal uterine bleeding, and then breast cancer treatment, including breast reconstruction. Overall, we've got 24,000 patients that we believe have a preference-sensitive care episode every year, and over 4,500 surgical procedures that might be impacted by the implementation of shared decision-making. What we've done is created a number of different options for patients to get access to decision aids. Providers can direct patients to the My Group Health, which is our secure web portal for patients to watch them streaming online. They can secure message the patient through email to let them know how to get on My Group Health. There's links to those videos that are embedded to after-visit summaries from a visit with a care provider. The providers can then also order the DVD for the patient and get mailed directly to their home so they can watch the video with their family and review the material before coming in to talk with the provider. So our Epicare system, which is our electronic medical record, has capability for ordering each video. And then the order information is also embedded into the after-visit summary to prompt the patient to remember to do so. As you might expect, with so many different clinical service lines impacted, there's varying workflows in each specialty that we have to work through to negotiate different strategies for implementation. But in general, the delivery of these decision aids has fallen into two models. One is the pre-appointment delivery, where we're identifying patients at the time of referral who have knee osteoarthritis and would likely be eligible for a decision aid, and delivering it to the patient before the visit so they'd have an opportunity to review the materials before they actually see the provider. The second type is where they come in and become diagnosed with spinal stenosis or abnormal uterine bleeding, and the provider's actually referring the patient to the video at that time, and they're going to be following up with them later. We also have a contracted network of providers and selected surgical specialties. We're actually reaching out directly to patients through mailed letters at the time of their referral to one of these specialty providers and letting them know that these videos are available to them. So we're reaching out to them and pointing them to the My Group Health patient portal to try to get this information in their hands. We're also then sending a letter on to the provider to let them know that this patient has received shared decision-making materials and where they can access those if they would like to review them. We're going to be following up with a comprehensive evaluation to look at the impact of these 12 decision aids on healthcare use, on costs of care and other ancillary healthcare utilization, as well as we're doing detailed interviews with the providers themselves to assess barriers and facilitators to implementing these decision aids and shared decision-making process in our physicians. We're going to be comparing in the intervention group, we're going to be looking at patients who are being enrolled from 2009, following them up on their treatment choices and healthcare costs over a 1-year period, and comparing them to an historical control of patients from 2007 to 2008 and what their treatment choices look like, healthcare use and costs of care. We're tracking the decision aid viewing, the procedure rates, their overall healthcare use for the patients, their costs of care, the cost of the decision aid delivery, and the impact of shared decision-making on providers and staff, as well as patient satisfaction with the shared decision-making videos. To date, since January 19th of 2009, we've delivered over 2,100 decision aids, most of which have been delivered directly by a provider through ordering, although a number of them have been delivered by their staff through direct ordering, or a smaller proportion through the web themselves. Patients have been generally satisfied. In our recent patient satisfaction survey, 92% watched most of the video, 87% read most of the booklet, 92% rated the shared decision-making program as good, very good, or excellent. So in conclusion, shared decision-making with patient decision aids can help patients make higher quality decisions with greater knowledge and overall equivalent health outcomes in 7 randomized trials. It meets a higher standard of informed consent and may reduce unwarranted variation in care. And our future evaluation will basically uniquely address the impact of implementing 12 decision aids in a healthcare delivery system. Thank you.
Thank you very much. I appreciate the opportunity to speak today about how we are changing the way surgeons communicate. I'm going to tell you a little bit about the way surgeon communication is with the prototypical example of sign-out. So this is the handover of patient care from one surgeon to another, primarily when you're going to leave for a vacation or, more commonly, overnight care of inpatients. I want to talk a little bit about the failed legacy of patient ownership, which is the fact that surgeons usually didn't want to turn over care of their surgical patients, lessons from high-stakes industries related to how they communicate in situations like this, and then tie it all together with what sign-out and what surgical communication and communication in medicine ought to become. So let's just talk for a minute about the sign-out of surgical patients. And I hope as I go through these slides, you'll see little pieces from almost everybody else's talk today, because we've talked about what's wrong, we've talked about how could we fix these things, and I hope to show you a system we put together that combines both of those into a solution. So the problem that we have with surgical communication, or in this case, sign-out of surgical patients, is there is no system. There's a non-system. Surgeons used to do everything themselves. They didn't let anybody else take care of their patients. Sign-out was for short overnight periods after the patients were tucked in. There was nothing for anyone else to do. And the primary surgeon, or in this case in academic medical centers, the primary resident, owned all the information about that patient, owned the whole process, and did everything. And just said, keep my patient alive overnight, I'll be back in 4 hours. So that was a very important invisible quality control mechanism, because that resident owned the patient and knew everything about the patient. There was no confusion about who the nurse should go to with questions. You went to the resident that was taking care of that patient. You went to the surgeon who was taking care of that patient. It wasn't like, well, I'm going to page night float. Nope, it's not me, it's cross cover. No, it's the day float. No, I'm just cross covering the day float because he's out sick today. There wasn't any of that, right? So it was also education for trainees, because they would watch a disease process evolve. They were always in the hospital. They never went home. They saw the effect of their therapy. But what we didn't realize is that it was quality control for the teachers. Charles Bosk wrote about this in the 70s. He said, if you didn't know the disease on rounds, you just needed to read some more. If you didn't know the surgical management of that problem, you needed to get to the operating room more. But if you didn't know who that patient was, why they were in the hospital, and what was wrong with them, that was a character flaw that meant you were unfit for the surgical profession, and you got kicked out. And nowadays, it's almost expected. Oh, that's not my patient. I'm just cross-covering. So this was a huge problem. And it's been made worse over the past couple of decades as Medicare and Medicaid brought residents into part of a healthcare non-system. And the inpatients became more complex, more acuity. There was more data to manage about them. And it became clear that one resident could no longer manage all the information about their patients, couldn't do all the procedures for their patients. The lengths of stay were decreasing, compressing all of this work into a very short space of time. And then came work hours limits. So now they have to go home. And so what we're left with is the prior way of managing patients, the patient ownership, and now suddenly we've got teams of residents that are constantly rotating and shifting and handing off. But we don't have a new system for residents to use. We've got this old way. We don't use teamwork. Patient information is poorly shared from resident to resident. Knowledge and decision-making exist in silos that Dr. Flum talked about. Inpatients today are sicker with rapidly changing conditions, and the command chain isn't questioned. And Dr. Carl would probably realize that this is the exact scenario that led to one of the worst air disasters in the 1970s. So we've got to fix this. And the problem is that our current methods of communication don't have a way of compensating for that loss of patient ownership. We know that cross-coverage is risky. We know that sign-out is unreliable, and we know that, that communication fails in surgery, and frustratingly, it fails in predictable ways over and over again. And these problems not only harm our patients and need to be fixed for that reason alone, but they worsen the surgeon's aversion to handing over care or for coming up with a method to do it that's safe. We don't want to learn a better way. We're not motivated to do it. So just a few examples of how we know these things to be true. Brigham studied in 1994, 3,000 medical patients. Preventable adverse events were more than 2 times as likely when a patient was being cross-covered. A lot of you have seen these studies earlier today in other people's slides. This is that Harvard study, 444 closed surgical claims. 23% of these problems were from communication failure. A University of Chicago a few years ago, they conducted post-handoff interviews with the junior residents that received the handoff of a patient. This was 26 medical interns, 82 patients, and they found recurrent communication failure modes, content omissions, and failure-prone processes. There wasn't a system in place for the residents that helped them do this right. Yale just last year looked at 503 patient sign-outs and found more than 7 problems per 100 patient days with, again, these recurring communication failures at sign-out. So if I've got a 20-patient service, that means every 5 days there have been 7 sign-out problems on my service. It's not tolerable. What have other institutions looked at? This is an Ohio State study from 2004 where they looked at previously gathered information about handoffs at other high-stakes facilities. This is things like Space Shuttle Mission Control, nuclear power plants, railroad and ambulance dispatching. And on this screen left side is the Yale study just last year. That's medical patients. And on the screen right, Ohio State University. And look at how these things match. The current clinical condition was omitted, and the current state of the system was not understood. And if you march down this thing, you'll see the same things over and over again. We know how communication fails. We know it from all kinds of industries. So, 5 main themes that they discovered in the 2004 study: communication quality and efficiency, supporting material and unofficial notes. So in medicine, this would be something else that I give you besides the chart. Unambiguous symbol of a completed handoff, a way to detect errors or to see missing information, and the opportunity to delay a handoff when you're busy or overwhelmed with tasks. And I want to point out, this is from the 2007 study, one more thing that supports this issue of problems with handoffs, and that is the trainee-to-trainee handoff is the highest risk handoff, okay? And the reason for that is I don't really know what I'm doing, and I'm giving this patient to someone else who doesn't know what they're doing. And how are they going to know to ask me a question about what if he becomes tachycardic? They don't even know what to ask, right? So we thought, what would a computerized tool do in a situation like this? We thought, it ought to lend itself to certain aspects that would fix this, like providing legible background information and providing you with a printed list of who your patients are, where they are, and what tasks need to be done. And we thought it would also be a tool that could teach you principles of handoffs. How do you structure it? How do you organize the information? If I don't know what to ask, but I know that there's a script that ought to be followed, if you don't tell me a piece of information, I can see it's on my script and you didn't say something for that one, and I can ask you, well, what do I do for tachycardia? Because that was on my script and you didn't say anything about that. And it promotes team-based care because everyone uses the same tool. So this is what we built. CORS takes resident-entered information and hospital clinical data. So the left side is this sort of unofficial information that the 2004 OSU study found, and this is the chart, basically. And it produces for you rounding reports, sign-out reports, and even pre-printed progress notes if you're still using paper. It's a web-based application available throughout the hospital and from home. You can free text information about your patients, like, the grandmother told us a bunch of medical information, but I'm not really sure whether it's true. I mean, would an intern write that in the chart? Probably not. But it's important to know. And not only that, but instead of just a printed list of medications from the pharmacy, this lets you put in, why was a medication started? What are we going to stop it for? Or would we change the dose for certain parameters tonight while on call? It's high-density printed reports that you carry with you, because as we all know, a nurse can find you through your pager wherever you are in the hospital, but you may or may not have access at that moment to patient information. So you carry this with you, and it can survive a fall down 4 flights of stairs, too. We studied this with a randomized crossover design. We looked at continuity of care, we looked at resident workflow, and we looked at safety. And what we found is that residents missed half as many patients on rounds because they didn't know they'd been admitted by cross-cover or transferred to the ICU by cross-cover. Residents spent more time seeing patients before rounds instead of sitting in front of a computer and trying to get information out of it. And they reported improved subjective quality of sign-out. In terms of their workflow, remember we said efficiency of communication was important. We found they spent less time copying data before rounds, which we thought was important because data copying errors are also a risk. We shortened the time that the team spent walking around the hospital seeing patients, hopefully letting them do other more important patient care tasks. And we did it safely. We found no change in any kind of errors, even though the residents were rounding in less time and they were spending less time sitting in front of the computer reviewing all their patient data. So just to wrap this up, what should sign-out and therefore communication in medicine be? Well, it ought to be what it always has been, about patient care. But it needs to be that in a new way. It needs to be about team-based care. It needs to be about communication with everyone. And a tool like CORS, the minute you update it, it's available to everybody on your team. It ought to be well supported with training and intuitive tools. But it also needs to get back to this original problem. The reason that we can't let go of all of this information and share it among a team is we need to have a way for teaching and quality control. So a system like CORS, imagine if you were a program director and you could look at examples of sign-out that your residents had typed into the computer and looked at examples of good sign-out and bad sign-out. There's a quality control measure related to communication. Most importantly, and I could spend a whole talk about this, is we have a self-image that I know everything about my patient and I do everything for my patient because it's a professionalism issue. But that's not safe care anymore. We need to know everything about our patient, and we need to do everything for our patient. So holding on to all this information and not sharing it is wrong. And we need a new self-image, one where it's okay, in fact, good professional practice, to share the information and make sure the entire team is updated. Thank you very much.
So I'm going to be talking for a couple of minutes about scope, and it'll be slightly longer than the designated time, mostly because the Life Science Discovery Fund, which has helped to support scope, is also helping support today's conference. But also because, it's scope, and it's called the Scope Box. It's a great opportunity to talk about it. I thought I would talk a little bit about how it applies as a novel application for dealing with some of the issues that we've been talking about all afternoon. So, because some of you know what scope is and some don't, and some of you know where we're headed with scope, but some of you don't, it's going to cover both aspects of it. Scope's a pretty unique deal. It's a Washington State project that's really been targeting quality and cost effectiveness in surgical care. And it starts with a pretty novel idea that the community might actually work together. So if you look around, you're going to see surgeons from the Tri-Cities area, from Sunnyside, from Yakima, from Moses Lake, from the Puget Sound area. It's an unusual way to start rebuilding connections between a community that's, frankly, over 50 years not had a lot of reason to work together. That alone goes a long way in helping to own the surgical, the problems of surgical quality and own the solution. And the novel aspect here, imagine this, you have docs who are holding the scalpel, defining what the metrics are that really should be quality, not people in Washington, D.C. picking metrics that seem to be pickable, or maybe they have enough evidence to pick through, or that the lobbyists haven't defeated aggressively enough, but actually docs saying, you know, this is what makes quality. I've been seeing quality for 20, 30 years in my practice, and we should measure on quality. And then the docs have to convince their hospitals that this is worth tracking on. It's a complete revolution in the way we think about quality, right? Medicare tells the hospital tells the doctor. That's the traditional way. Scope's an inversion, and it's a novel approach to trying to improve healthcare. So what's the mechanism? It's really as simple as something that all of you had in elementary school and junior high school and high school, but somehow stopped in med school. The idea of a report card, a benchmark, a way of knowing how am I ranking, how am I doing compared to my colleagues, something so elemental that the thought that when all the evidence finally goes away, when you're really finally a doctor, that all of a sudden you would not have benchmarking, that is really part of one of the key elements to why we're in trouble as a healthcare system. So it improves through benchmarking. And then, because benchmarking isn't good enough, you really need interventions based on that benchmarking that change the system. So the key component of scope benchmarking is a report. That right now is a quarterly report, but soon will be closer to a real-time report. Regional meetings that help build energy around those reports, phone calls, state meetings, meetings in restaurants in eastern, northern, southern, every aspect of Washington you can imagine. Newsletters, literally called the Scope Box newsletter, and interventions that we're going to talk about shortly, and then Dr. Dellinger is going to talk about. So why scope? There's a lot of other things out there. There's a lot of ways to measure quality. You've heard some of them. First of all, it uses real data, and the best way to get a surgeon turned off to a project is to not have real data. These are real data derived from the clinical chart by experts who know how to abstract information out of a chart. Second of all, it changes not just fill-in-the-box kind of mentality, but it changes behavior and it's changing culture. And it comes back to what we talked about before. The idea that the surgical community actually is a community and has a responsibility as professionals to own this, that's a culture change, and that's what Scope is doing as well. And then the ownership is shared, and I want to highlight that for a moment. This is not a University of Washington project. Scope has a lot of owners to it. First one is the Foundation for Healthcare Quality, a nonprofit activity in Puget Sound that brings people to the table that normally don't like talking to each other, like trial lawyers and doctors, and other groups that need to come together and talk about things and work out solutions. The Foundation for Healthcare Quality is really the aegis under which Scope works. Then there's Surgeon-Led Management Committee, and is Mike Florence here? Where's Mike? Yeah, Mike Florence has been running a surgeon-led management committee, a surgeon at Swedish, Rick Thurlby at Virginia Mason, Steve Ellerding over at Sunnyside, surgeons from across the state, including my own boss, Patch Dellinger, who's been on the management committee since it started. Surgeons who have come together for the purpose of really owning this as a community, not as a pet project of the university. It's also part of the state chapter of the American College of Surgeons, and it's taken this into their leadership and into the role that they want to play from a policy and advocacy perspective. There are over 500 surgeons and now 55 hospitals across the state that are engaged. The governor's office stands behind this. The Life Science Discovery Fund, which was a fund that was developed from the governor's negotiation of the tobacco settlement, ended up supporting a lot of the expansion for Scope, and just shows you how you can link a public policy initiative of the legislature to a community grassroots activity, and ultimately Source, which acts as the academic home for the Scope project. So those are all the people who own Scope, and because so many people own it, that's where it has its real strength. Lastly, it works to engage the hospital leadership that pays for the project by creating a set of metrics that I'm going to show you later that really matter to the bottom line of hospitals, and we'll talk about that in a moment. So Scope started small, conversations by surgeons at a couple of hospitals in Puget Sound, but then spread. the way you would expect a grassroots initiative to spread if it was the right thing to do for the right reasons. And it's spread across the state in rural areas and urban areas and poor areas and rich areas and blue and red parts of the state because it makes good common sense and it resonates with every surgeon who picks up a knife. And ultimately, it's because of results like this. This is rates of reoperative surgery, complications after a colon operation. When we take out the colon, we put the two pieces together, but that thing leaks and needs another operation. It's tracking rates like that and showing them drop quarter by quarter by quarter that really are the ultimate reason why we do scope. And that's the kind of outcomes we're seeing. Now, why do they change? I don't know exactly why they change. Part of it is, as Dr. Cheney said, if you look at something, it'll change. It's the Hawthorne effect. But there's probably more to it. Scope is really about benchmarking to change behavior, as I mentioned earlier. Let me show you one behavior that we think has changed. When you do take out that colon, if it's on the left side, you have an option at the end of the operation to check if that connection you made is leaking. Putting air in the colon, the way you check a tire to see if it's leaking. And you can either choose to do that or not choose to do that. And if you choose to do that, you can identify a leak in the operating room when it can be fixed. And if you choose not to do it, you'll have to wait to the next day when the patient's on the floor to figure out if it's leaking. Now, that's not how all leaks happen, but some leaks happen that way. And the studies showed that you can drop the risk of leaking by half just by checking. So why wouldn't a surgeon check? Well, maybe they weren't trained, like Dr. Van Eaton said. Maybe they weren't trained, or the way Dr. Wright said, maybe they weren't trained in the best way to do a surgeon this operation, which is to test for leaks. Or maybe they just don't believe. They don't want to change their behavior, like Dr. Hull was talking about earlier. That's just the way they do things. They don't want to change. Or maybe they don't think it's in their mindset to really modify what they do. That's the way they've been doing it. Well, scope works to change that behavior. And you see, once again, quarter by quarter, an increase in the frequency, the rates of how often people are checking for colons to see if they're leaking. This isn't changing because of Hawthorne effect. This is changing because it's a fundamental thing. When you find out how you're doing compared to your colleagues, you modify behavior. It's a powerful tool. And it's here for leaking in colons, but it's also for things like avoiding transfusions. The arrow is going in the right direction, right? Fewer and fewer people are getting transfusions. More and more of these cases are transfusion-free, which is what this slide is showing over time. Here it's getting better management of diabetes in the operating room. So you're measuring diabetes, you're measuring blood sugars, you're working to decrease blood sugars by using insulin in the operating room and avoiding hyperglycemia. We know that as these rates go up quarter by quarter, the risk of infection goes down. It even works in a multidisciplinary way, getting pathologists to check the right amount of lymph nodes when we take out a colon specimen for cancer. You know, if you check many nodes, you get to find out if the patient really doesn't have any metastatic disease. If you only check one node and there's no metastatic disease, maybe it's just that you didn't check enough nodes. Getting to 12 nodes has become a bit of a standard. Our pathologists, when we were talking to them about that, didn't even know that's what we wanted. Quarter by quarter, you see the rates of getting the right amount of lymph nodes going up. Why? By benchmarking, by education. Very basic principles. That's really what scope's about. So let's just talk about how we got here, because I think it's a message to how others might move in a similar direction. Scope started to do recruitment. It's only a 4-year-old project, and we've already moved from 1 or 2 hospitals that thought it was a good idea to almost every hospital in the state. We cover about 90% of the surgery in the state of Washington right now. Then there's some strategic growth. We started really simple. Remember, the surgical community had never done this before. Docs talking about what they do and sharing their data on their results. That's unusual. Just start with an appendectomy, something that's not so threatening, unless you're the appendix. You know, and then you build from there. And then you add more complex care, colons, and maybe other specialties like vascular surgery, where it gets a little more complicated. And then add other domains. So Dr. Thirlby before mentioned that the elephant in the room that nobody's talking about is appropriateness of care or innovation, all the costs of care that are driving up healthcare expenditures that they're working on in the other Washington right now. How is Scope working on that? And that's what I thought I would spend a few minutes talking about. Lastly, we add some anchors, things that make Scope work, like a checklist that Dellinger is going to talk to you about in a second, or the fact that the Board of Surgery, the American Board of Surgery, now recognizes Scope as meeting maintenance of certification, what Dr. Pellegrini was talking about earlier. Lastly, I think the way this lasts is that you empower the community. Every surgeon out in this audience who's part of Scope gets to own it and feels like this is what it means to be a surgeon in Washington. And that can be a cool thing. So let me just tell you a little bit about where Scope's headed. because it's clearly been focusing on things like, can you get blood sugar controlled in the operating room and getting leak testing controlled? But from a hospital's perspective, that's neat that you were working on that, but that's not a bottom line issue. This is a bottom line issue. An initiative we're calling Scope Plus, for lack of a better term, that focuses not only on quality, but also on the supplies you use in the operating room to deliver care. It focuses on benchmarking docs and hospitals, docs saying, we want to know how efficient are we at delivering care? How often are we using more expensive equipment when there's a less expensive alternative? How much are we helping or hurting the profit line when we're involved in these things? By focusing on drugs and supplies and testing. Scope's also working to educate docs. Most docs have no idea how much one of those supplies they reach for off the shelf costs and what its impact on the bottom line is. That's what Scope Plus is working on and really helping make the business case. But I want to talk about two areas that Scope is really moving into that distinguishes Scope in a lot of ways from anything else and something you should all be looking forward to down the line. We are continually innovating. We're tinkerers. You heard about the FDA before. We are tinkerers, and there will always be new devices that come into surgery. How do we know that they work? Their spread's hard to predict. We know that once they get into the hands of surgeons all over the nation, it's hard to know how their outcomes are. There's a MOD process called the Manufacturer User Facility Device Experience. This is from the FDA. Any one of you can report when a piece of equipment doesn't work well or a trocar breaks or hurts a patient. That's the only mechanism we have to do post-market surveillance on instruments in America. That's it. If whether or not you call, that's how they find out. And when enough people complain, things get pulled off the market or they get evaluated again. That's a pretty bad system. Scope has a better way to do it. But it's hard to track on the safety of pieces of equipment. 60% of the surgery we do is outpatient surgery. The patients are home by the time they have the adverse outcome. How do you track on that stuff? That's where Scope is working on. So enter a new device, like single-port laparoscopic surgery. This is take the trocars that you use for laparoscopic surgery, maybe there are 3 or 4, and then take the operation and turn it down to one port this big and change the instruments so you can do everything through one port. That's innovation that will be spreading throughout, is already spreading throughout the nation. Scope has the ability to track on its use, so Hospital D can look how it's doing compared to Hospital G in frequency of use. They can compare in pain scores after laparoscopic surgery. As Scope brings in modules to look at patient outcomes like pain, you can start understanding whether or not this single port stuff is worth it or not. And lastly, will bile duct injuries increase or other adverse events happen more often when docs are using instruments that are cross-eyed and small or angled because they're trying to do the operation through one port? All these questions are answerable when we build a community of 55 hospitals and hundreds of surgeons that are willing to track on this stuff. And that's just innovation. Here's the last thing Scope's working on. I call it the dirty A word, because it is the dirty A word. Nobody wants to talk about appropriateness. They talk about 1/3 of all procedures are done in patients who may not even need them. How is the surgical community going to own that so that somebody in the other Washington doesn't tell us how or when it's appropriate to do surgery? Well, it's an A word, it's a dirty word because it questions surgeons' judgment, their knowledge, their professionalism. There are few standards to judge when it's appropriate to do a case, and it rarely incorporates a patient's perspective. A patient who's fearful of having their colon explode when they have diverticulitis, they may want to get their colon out right now to prevent it from exploding in the future with diverticulitis. Is it inappropriate to do that person's operation? I'd argue not, but we have no way to track on that right now, do we? And that's the problem with appropriateness. There's no meaningful way to track on it. But Scope can do that. So these are Scope data on the percentage of a hospital's cases for colon surgery with diverticulitis, where the indication is elective surgery. In other words, when the surgeons are doing sort of preventative surgery to prevent that colon from exploding in the future. And you'd think if we all had similar thresholds for when we operated on people, that you'd see some consistency in the numbers. To me, this looks like a scatter plot with widespread variability. And when legislators look at this, they think, well, obviously some surgeons are trying to operate on more people than not. It's probably much more complicated than that. Let me show you what Scope does with things like that. Scope's convened a colon surgeon group. It's about 15 surgeons who say, yeah, I really specialize in colon surgery. I do a lot of this. This is what I like to do. And that group has identified the kinds of variables you'd want to know about if you were really going to make some assessment about appropriateness, if you were going to tackle the elephant in the room, like how many attacks did that patient have, and how much complicated disease did that patient have. And then the Scope tracks on that stuff by encouraging surgeons to dictate that information into charts. We track on it, we benchmark on it. That's the way we think we tackle appropriateness in Scope. And it's tricky. I'll give you one other example, and you see how tricky it is. Surgeons who do rectal cancer surgery are trying to always figure out, is this an operation, can I do an operation on this patient that saves the patient's sphincters, that allows them to have continence after surgery? An APR is an operation that renders the person with a permanent colostomy. Some view that as the worst outcome if you have rectal cancer, especially if the patient's sphincters or their continence could have been saved. Well, anybody could look at rates like this. These are scope rates of how often an APR, a permanent colostomy, is used in patients with rectal cancer. Now, you might think these should be fairly consistent numbers, right? If we're all using the same, if we have the same skill and the same judgment. It's more complicated than that. And scope surgeons know that. So rectal cancer surgeons, about 6 of them from the 6 institutions that do rectal cancer surgery, have created interest groups. And they come together and they define what are the things you'd want to know to understand APR indications, like was the patient continent before surgery? Things that are important to know, right? It doesn't make sense to do a continence-preserving procedure if they don't have continence before surgery. Things like that, and then they become scope metrics, and that's the way scope works on it. So what's the future? I'd like to think about this. How would you build the healthcare system? Right? If you were going to build a healthcare system from scratch, you try to keep the patient central, right? You'd try to create a tide that raises all the boats. You can't regionalize everything. And you try to get us, the community, to own this problem. I think that's what scope is trying to do in a nutshell. It's trying to rebuild the system. You try to sustain that through a good business case, and that's what we're working on. And I think you'd ask the question, shouldn't everything be scoped? Why would any of you walk into a hospital for a procedure if you knew the procedure wasn't being done and surveyed in this way? So scope is a growing concern. There are a lot of people involved in it. Many people in this audience, in fact, have been involved in it. I thank all of you for your participation in it. It'll only survive if it has that kind of community engagement. Thank you for the opportunity to share this work.